Kandil from Tulane University to share a bit of his experience in the management of thyroid nodule using microwave. And please, we have Dr. Kandil here.
Thank you, Eric, for the for presentation. Can you hear me well?
Yes, yes.
Excellent. So it was very unfortunate that I was unable to make it to the meeting. My flight was canceled because of the unfortunate event that happened with the American Airlines. So I tried different things. I spent a few hours in the airport, and unfortunately, I could not make it last night. And it was kind of dangerous to try today and be late for the talk. So I was honored to have the first meeting in New Orleans, and I definitely plan not to miss this meeting ever. So today I will be discussing the microwave technology and the management of thyroid nodules. And here is the agenda. I will just show you some case presentations, and then I'll talk about the technology and then discuss some of the published data, and I will share with you personal experience that's not published yet, but I think is very interesting to look at it. So I can tell you I've done over like thousands of radiofrequency ablation procedures, and I was very happy with the technology. But after meeting with my dear friend, Dr. Mengao Zheng, he told me that in China, a lot of the physicians moved from radiofrequency to microwave because of the better efficacy, etc. So I did go and visit, and I'm here to tell you about what I learned about all this. So this is here one of our first papers on the topic with the radiofrequency ablation. It was multi-institution study with the Johns Hopkins group. And what I want to highlight that we showed that the extremely vascular nodules can really have problem with radiofrequency or a lower chance of response to the radiofrequency ablation. This is another follow-up study with Johns Hopkins and Stanford, and we had over 600 benign nodules. And again, what I want to highlight from that paper that we learned few things. In addition to the vascularity, the volume of the nodule affected the response, as you all know. So you can see here that larger nodules have significantly lower response and lower volume reduction rate compared to smaller nodules. And that was very clear from the combined data on all the institutions. So here we go. Here is a 75-year-old female patient who had a thyroid mass that causing some compressive symptoms, but the biopsy showed some follicular neoplasm, and the Afirma genetic testing showed that the risk of malignancy was less than 4%. But due to the compressive symptoms, we decided to do an ablation procedure and avoid the surgery. So the nodule was vascular. And the response after the first ablation, the volume reduction rate was 22%. And I will show you here, I make these tables and I share it with my patients, just an Excel file showing the volume and the response. But you can see initial response was 30% and then went down to 22%. So the nodule started to increase. So we decided to proceed with another ablation a year after. And we had a better response. You can see here initially the volume reduction rate was 51%, but the nodule started to grow again because it was extremely vascular nodule, so started to grow. So at that point, I started doing the microwave, and when we offered this patient microwave 3 months after, you can see that we are able to achieve close to 80% volume reduction rate. And I actually saw this patient yesterday in the clinic, and this was again as a 6-month follow-up, or maybe now 7-month follow-up, and she continued to maintain the volume reduction rate of 80% with complete resolution of her compressive symptoms. So what I would like to highlight here is the heat sink effect. So the heat delivered by the microwave is more uniform because of the less effective heat sink. So the heat sink effect will happen to both radio frequency and both microwave technology. The problem with the radio frequency ablation that the the current, the electrical current, will travel down the path of least resistance when they are near a vessel. So these vessels will literally absorb the heat generated by the radio frequency ablation. For that reason, the microwave can produce better results in these cases that are has nodule that's extremely vascular. And multiple papers for sure, and anyone who tried both the microwave and the radio frequency ablation will tell you that the microwave is definitely faster, specifically when you are treating a lot larger nodules. Um, and you also understand that when you treat like vascular nodules, you try to treat the feeding vessel. So there is like a surrounding feeding vessel. You try to get that to avoid also the heat sink effect, which is significantly less with the microwave. So the microwaves definitely provide precise and long-term results and safer also for patients with surgical implants and cardiac morbidities. One of the issues with radiofrequency ablation that is not FDA approved in patients, it's actually off-label to use it with patients who have ICD or pacemakers. And we had an experience with this, and we're about to publish a paper on a series of these patients with radiofrequency. But you need to ensure that the cardiologist involved and you had the clearance. You need to make sure that you have the cardiac device manufacturer rep, and you interrogate the cardiac device as needed. You need to place magnets. So we have to do these in the OR and the monitoring session. You cannot do these like in an office without any monitoring session. And with the microwave technology, you do not need to use any of this because it does not use this parative electrodes, and it's absolutely safe to use it in patients with implants and cardiac defibrillators. Also, for pregnant patients, there is no contraindication to use the microwave technology on these patients. So microwave, again, is a thermal energy methodology to treat these patients. So it's a hyperthermic reaction that's generated by the microwave with electrical field. And we use an antenna, a probe that the frequency can go between 900 to over 2000 megahertz. And the oscillating charges of the microwave will generate again friction and heat that will cause coagulative necrosis, and the collision by the ions will generate the heat that will lead to the kinetic energy. So the Baird medical system will have this generator. It's a very simple generator, and then you have the antenna that will be connected through a cable to the machine. One thing really I like about the using the Baird Medical that there is always a rep in every single case. So you don't need to really worry about the setup and all this. They will provide that service for you if you elect to try to use this. So with there is a sensor at the antenna, and the shaft distal to the probe at the tip is cooled like at using water at 0 degree Celsius, and the diameter of the coagulation zone can be changed according to the power. What that basically means that if you are in the middle of the nodule or away completely from vital structures, you can increase the power to provide more energy. And we all know that providing more energy will lead to a better outcome in these patients. But if you are very close to the vital structures and the dangerous triangle, you can decrease your power. Most operator will just use one power, which is anywhere around 25 watts, but I like to increase the power in the middle of the nodule away from the vital structures. So I visited multiple institutions in China, and I learned about a lot about their technology. And I think it's always good, even when you think you know a lot, there is always more to learn. So definitely they have a very precise technique to make sure that they burn all the nodule. And I always say that in order to provide this treatment methodology, you need to be very precise with your biopsy technique first before going into this, and you want to make sure you burn the entire thing. So they use the same thing with the standard technique for radiofrequency or the hydrodissection, etc. So that's a must. But what they routinely use also is the contrast enhanced ultrasound. And I've been trying to do this. There is actually RVUs here, and there's a code for this technology. None of us in US use this. But what I loved about this, that at the end of the procedure, you can see here pre and post after the contrast enhanced ultrasound. And if they see any area that's highlighted at the end, they can go behind that area and target it to make sure that they are not missing it. Because sometimes with the enhancement, with the procedure enhancement from the ablation, you might miss an area, but with this technology, you should be able to avoid this. So there's a lot to actually learn to improve the technique that we are doing here in North America. So again, you can use the same technique as the radiofrequency ablation with the transasemic approach, staying away from the dangerous triangle with the moving shot technique. And many of them will use this. But what was very interesting that I found that many of their operators and um, they use different techniques with the direct approach, going directly into the nodule, and sometimes even completely lateral approach. You keep doing the same thing. You stay away from the dangerous triangle. And the key is to make sure that you burn the entire nodule and to control that very well and make sure the entire nodule is good. And you use the same technology with the same technique with the hydrodissection, staying away from the vital structures, etc. Looking at the published data, this is a paper that was just published in Radiology. It's a multi-institution study, prospective, randomized, open-label trial. And it has 5 institutions, and they looked at data from 2019 to 2023. And again, it's from China. And what they did, they randomly assigned patients 1-to-1 ratio to receive either microwave or radiofrequency. And they have 75 patients in each group. And the volume reduction rate was 91% for the microwave group versus 86% on average for the radiofrequency. But again, because of the number, that was not statistically significant. And there was also no difference in the risk of the reported complications. So if you look at the literature, most of the studies showed that the outcomes are similar. Definitely microwave is faster, specifically in larger nodules. And you can find, for example, sometimes that some studies show that the radiofrequency can have better outcome, but in the same study, you will find that when they look at the experience of the operator, they found in the experienced hand for operator who've been doing this for a while, there is no difference in outcome. So if there is an early operator, early their experience, they might find difference, but otherwise there is no difference. Another study here, a large single study, looked at 1,180 thyroid nodule, and the volume reduction rate that was reported 92%. And similar to the radiofrequency ablation, there is no effect on the thyroid function test and the thyroid function. Multiple studies showed at a long-term, 12 months, the volume reduction rate, again, 90% with the microwave ablation. So I like this study. It's a lab setting, an animal study that they actually try to compare in a controlled setting the radio frequency versus the microwave. I mentioned earlier the heat sink effect. And for that reason, if you talk to any interventional radiologist, they tell you that's why they are not doing any more radiofrequency ablation for liver tumors, etc. And they are more towards the microwave or cryoablation because it provides more energy, etc. So in that study, they looked at ablation 10 minutes after ex vivo bovine liver tissue, and they did CT images of the liver every 15 seconds. And this is the summary of the study. You can see on the top is the effect of the volume reduction rate for radiofrequency ablation. And with the microwave, you can see significantly lower, more volume reduction rate. And at 50 watts, it can go to over 50% with increasing the power, increasing the watts for the microwave, you will have almost a significant response. So the more power you put, as we understand, the higher results you will see. And again, it just talk about the heat sink effect, a comparison between the microwave and radio frequency. So the conclusion of the study that microwave demonstrated a greater contraction, the radio frequency was similar energy level. So if you compare apples to apples, meaning that to provide the same energy level, the same number of watts, you have much better outcome with the microwave. And you can definitely have, as we know, a better volume reduction rate with the higher power levels. So if you look at complications, most of these, again, another randomized control trial from China for benign nodules, comparing radio frequency to microwave, and complications again were similar. This is one of the largest studies that looked at microwave ablation for PTMC. And again, multi-center study, prospective study, and almost 1,300 patients were included in that study with a mean follow-up of almost 35 months. 10 patients in this group developed eventually sentinel lymph node metastasis. 1.1% developed hoarseness of voice, and all recovered within 6 months. But the outcomes were very similar to the outcomes of the radiofrequency ablation. We recently published meta-analysis comparing the T1A and T1B with the ablation and showing that it can work good for both T1A and T1B, but definitely much better outcome, much better volume reduction rate and higher disappearance rate as expected with the T1A. Another study here looking at, I love the study from China. They actually had 10 patients with 11 PTMC. And after the ablation, they decided that they're going to just take them to the OR and undergo the thyroidectomy. And what was interesting, there was no residual disease found on the ablated area. However, they routinely did a central lymph node dissection. And in 3 of these patients, there were central lymph node mets. And as we know, most probably this is completely not clinically significant. And as we all know, if you want to start a fight in an endocrine surgery bar, you can talk about prophylactic central lymph node dissection, but this is not the topic here. I like this paper too about microwave ablation in pediatric population. And in this study, they included 25 pediatric patients with 34 symptomatic benign thyroid nodules. And the volume reduction rate here, as you can see, on average was 85%. And almost 18% of these nodules completely disappeared with the microwave ablation. The symptom score decreased from 5.5 on average to 2.4. And also there was significant improvement in the cosmetic score. And as we mentioned earlier, the thyroid function tests were not affected by the microwave. So here's my experience with the microwave. I have done, I think, close to 130 microwave ablations so far. But the 19 of these patients underwent microwave after RFA. And after the RFA in this group, we had like maybe a volume reduction rate of 39%. And these patients underwent microwave following the radiofrequency ablation. And on average, the volume reduction rate was 62%. So in these 19 patients, in my experience, that did not have a very good response initially, with an average around the mid-30s, 33% or so for the volume reduction rate after the radiofrequency ablation. When they underwent the microwave ablation, it was significantly better. One can argue here that, well, if you do another RFA, you might have a similar results. But I showed you earlier a patient that has already two radiofrequency ablation prior to the microwave. So there is definitely published data, and we know this. If you do multiple treatment session, you can have a better outcome. But I mean, these patients literally kind of failed. We consider success rate over 50%, but they failed with the radiofrequency ablation. These are patients with larger nodules or increased vascularity. And we were able to see that there is a significant improvement on the volume reduction rate and the response using the microwave technology compared to radiofrequency ablation. So I will end with this slide. I think this is really a take-home slide, but in conclusion, microwave ablation is definitely a novel and safe, effective technology to treat not just benign nodules, but also malignant nodules in adults and pediatric population, and can really provide significant advantage over other thermal technologies because of the less heat sink effect. I will close with this. I know that most of you are doing radiofrequency ablation and happy with it so far, but as we know that I love this book about ego is our enemy. There's always things to learn and things to improve on, and the same. I always learn from others, and we learn from each other. And I think with Baird, we are able to provide also multiple training. You can see in the picture, actually, very experienced endocrinologists who are doing this, but they are coming to see how we do this, and I learn from them. We learn from each other. And I think I always say, if I can do it, anyone else can do it too. But what I love about Baird, that they are able to help with educating the physician with a good training course in a short time, and also making sure that you have a rep in every single case. This is the end of my presentation, and I will be very happy to answer any questions. And I'm very sorry that I missed this meeting. I just feel so bad about it. But thanks again.
Okay, thank you, Dr. Kandil, and thank you for everyone for listening. Now, if we have any questions, feel free to come up to the podium, and we can use this mic to ask Dr. Kandil.
Everyone understood everything, no questions. I can't believe it. No one is trying to give me any hard time. Even Dr. Tufano doesn't want to give me a hard time. I can't believe it.
Anyone? Any questions? Yep.
If you're more aggressive, Dr. Hamilton, this is Mike with UCLA. Just more aggressive about hydroprotective maneuvers, and I know the complication risks are similar, but if you feel like you have to be more cautious given sort of more aggressive nature of microwave ablation for start.
Sorry, did you hear that, Dr. Kandil?
Oh, can you repeat the question for
Okay,
me?
can you use the speaker?
Well,
Hey, it's Mike Duke from UCLA. How are you?
Hey, Mike, how are you, man?
Yeah, good. Just the question I'm curious. I know complication risks are reported to be similar, but given, I think, the more aggressive nature of the microwave ablation, the lack of kind of the protective heat sink effect for things like the vagus nerve, if you're more cautious hydroprotecting structures, if you're more aggressive about administering D5 to protect those vital structures with microwave than you are with RF, or if it's the same technique.
Thank you, Mike, for the question.
Thanks.
We all know that Mike is a leader in this field, and he's very experienced, and this is very important point, Mike. I 100% agree. And for that reason, I have to say, and if I'm treating, for example, a small lesion like a PTMC or something close to the dangerous triangle, I will definitely use radiofrequency ablation. And I would be worried about the energy level. I don't think, though, there is data specifically about you use more hydrodissection for microwave compared to radio frequency. And when I give lectures before on hydrodissection, and when you look at the published papers, there was one paper that claimed that the more volume you put the safer it will be. But when you look at the data, they can't show this from the data. This is their hypothesis. That's what they think from their experience. But it makes sense that if you are worried about certain area, the more hydrodissection you do, the better things will be. But as a surgeon, also, we know that the nerve can be adherent to the thyroid at some point at certain areas. And maybe hydrodissection would not get the nerve far away if it's like adherent with like some fibrous tissue or scarring tissue, etc. So yeah, I think you need to be very careful close to dangerous triangle. Obviously, close to the carotid or the trachea, you can be safe if you put more hydrodissection. But this is a very good point, yes. But it will be really a good thing to, I mean, the thing is honestly that the risk of complications in experienced hand is very low. And in order to show that more hydrodissection and will be associated with lower risk, you need really a high powered study. Like the power of the study should be really big, which is not going to be maybe feasible. So that's the problem with the design of these studies, because the risk is extremely low in experienced hands. And as you all know, many would recommend, for example, continuous hydrodissection. But I think with experience, you just want to make sure that you're staying away and you provide more hydrodissection. But you also can go down on the power for the microwave. I think there's another question.
Yeah. Hey, Emad, Rich Harding from Phoenix.
Hey, buddy, how are you? How are you?
The question I have is regarding the necrosis and the gangrenous necrosis that you get after the treatment. So I think we don't always talk about this. We talk about how the volume reduces, but some patients get that big necrotic area and it just doesn't keep shrinking. It just stays there. And it doesn't seem like there's any point to retreat an area that's already necrotic. You know, if you study it, doesn't have any blood flow. Is there a difference in microwave patients and how this necrotic gangrene is processed that's different than RFA? Because that would account for why that's shrinking more than it does with RFA.
So, Rich, this is also an excellent point, and I think the issue here, honestly, is we don't do the contrast ultrasound. None of us do it, and I think maybe we should consider including this in our practice. But this, as you know, it's not easy. I mean, for me, I had to put this through the hospital administration and all this, and they have to look at numbers. But if you do the contrast ultrasound and you see an area that is not viable, then I would agree with you that there is no point of trying to ablate this. But I'm not sure if just looking at the ultrasound, maybe you're better than me on this to guarantee that this area is completely ablated and will not benefit from an additional ablation. I think the answer to this question is doing a contrast ultrasound, and that's something that I really hope that we will all be included, including this in our technique in the future.
Okay, thank you, Dr. Kandil, for your excellent answers. Yeah. If anyone else still have any question, please feel free to come up. Otherwise, yeah, thank you very much. And we hope we can stay connected. And we're happy to, again, really appreciate Dr. Kandil's presentation today. Thank you very much.
Thank you. Thanks all.
Thank you.